Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Jay Keese from Capital Advocates about Beyond the Copay, DPC, HSAs, and the politics of change. Let's get started.
Hello, Dr. Dan. How are you doing?
I'm good, Faisel. How are you?
I am very, very excited for today. I mean, today we're recording a podcast episode, but it's like the first day that I can officially celebrate a huge win just for primary care, direct primary care in general. It's just in the last couple of weeks, For Jay, welcome onto the show.
Good to see you guys.
Good to see you. I'm just thrilled to have you at summer vacation. I've got 4 boys, so I'm towards the end of the 10 weeks of summer vacation. And they didn't understand our excitement that we were having with this monumental bill passing, and now I get to celebrate it with you today.
I would love to hear. My understanding is you started out working at the AMA. You have worked in Congress. You have worked for health IT companies, and you've decided that your passion's really around improving the doctor-patient relationship with this direct primary care model. How did that come about? Because my guess is you could have worked for anybody, and there's some much deeper pockets than who you've been working for.
My story with DPC, you're right. I worked on Capitol Hill for a number of years, came to DC 40 years ago to work for Senator John Hines from Pennsylvania, who was one of those things that don't exist anymore, a moderate Republican who could get an 80% rating with the AFL-CIO and an 80% rating with the chamber in the same year. But, I was approached by Dr. Garrison Bliss, who was the first direct primary care practitioner in the country during the debate over the Affordable Care Act in 2010. And, Garrison came to me and said, this Affordable Care Act thing is great. We want everybody to have coverage, but the reality is it's going to destroy this great little thing we've done in Seattle, which is to, take primary care outside of insurance, let employers or individuals purchase primary care directly, and we can do all of this for $60 a month. Look at what we're doing. I'm like, first of all, I didn't really believe him because they're like nobody can do anything for $60 a month. And then, started talking and got into it. And I said, the thing is, this is a train that's already almost at its destination. We're not going to be able to stop the train in its tracks. So what if we could get a provision in the Affordable Care Act, which allowed the direct primary care medical home was the term of art that we used, and the qualified health plan to work together to otherwise fulfill the requirements of the essential health benefits requirement in the ACA. And that's what we did. We worked together. We put that provision in the Affordable Care Act. We got it passed. If we had enough time, I'd tell you the war stories over that, but we'll focus on the more recent war stories. But, one of the big questions we had along the way was, well, are we just doing this for Dr. Bliss in Seattle, or is anybody else doing this? And at the time, there were probably, 100 or so practices in 20 states that were doing this. And Garrison wrote him a letter and said, hey, you guys want to join us in this fight? And we're going to create the Direct Primary Care Coalition to try to make sure this policy survives the Affordable Care Act and gets better care to people. And virtually every one of them said yes. And so we formed in, I think, 2009, the Direct Primary Care Coalition to help us get that bill passed. And, here we are in 2025 with another victory under our belt, which we'll talk about. But, the direct primary care movement has grown to, well over 3,000 practices around the country, everything from, you've got Nextera and, One Medical that used to be IOR having, 30 plus states, locations in 30 plus states and, thousands of lives to, Dr. Marguerite Duane, who's in DC and has a 40 patient panel and does house calls. And those are all DPC because it's all primary care paid for outside of insurance reimbursement. I'm passionate about it because it's just a great policy. And we'll talk about this when we dive into some of the finer points of the bill that we just passed, the Primary Care Enhancement Act. But it has the capability to be transformational. there are some hurdles that are in the way that we need to dispatch with. And, we just dispatched with a big one, which was the tax code. So by fixing the tax code to define primary care services as what they really are, finally, I think we're in a good position to launch from there. But yeah, I think you're right. I appreciate your understanding that this has been, for a lobbyist, a little bit of a labor of love. You all haven't been the best paying client in the world, but I think you've been the most meaningful client I've ever had, because I really feel like we're at a tipping point where we're gonna change the way people get their health care in a very meaningful way, and it all starts and ends with primary care. So that's kind of my journey. And you're right. Along the way, I've worked with health IT companies. I helped to write some of the provisions in 21st Century Cures that would levy $1 million per instance fine on EHR manufacturers that knowingly block the seamless transfer of data from one system to another. We've worked over the years to try to help. The real use of IT is in letting doctors communicate with their patients in the way everybody else communicates with their patients. And, DPC has been the use case for that. You mentioned COVID, everybody went to telemedicine in COVID. If you were practicing in DPC, you didn't go to telemedicine. You just called your patient on the phone the way you normally do. So these are all breakthroughs that I think direct primary care can have an impact on. And the way I like to put it is, when in every other payment model for care, you are paying for services. You're paying for widgets. You're paying for 99124s or whatever it is. You're paying a fee for a service, and oddly, you all have agreed to get reimbursed, paid in arrears, which no other business really does. But we could get deep into how that happened, years ago. But the reality is, the value equation for DPC is very, very different. It is that the thing you are purchasing, whether you're an employer purchasing it on behalf of your patient or the patient purchasing it for his or herself, is you're buying a relationship with a primary care doctor who's going to be your spirit guide through the healthcare system, hopefully for most of the rest of your combined lives. And that, to me, and as a patient, I can tell you that is exactly where the magic happens. And there's no other model of care in healthcare today that does that the way direct primary care does.
It's been such a long time for this, though, with the IRS rules. You would think that. That's the thing. You've been fighting this fight. I remember when I first heard about it many years ago, like, oh my God, really? It just makes no sense. People now have HSA accounts became pretty regularly available. You're funding this, whatever the maximum was, $5,000, $6,000 a year. And now you've got an opportunity to use that money to pay for access to a doctor, to have that relationship with a doctor, but you can't do it. So what were some of the delays? And then I'd love to just know what it felt like for you when you finally saw that language and actually pass.
Well, first of all, I would say, if you ever want to do something really, 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 really hard, go try and change the tax code. You have a lot of forces working against you to make any kind of changes to the tax code, beginning and ending maybe with the Department of the Treasury and the Internal Revenue Service, who really doesn't like a lot of change, really kind of likes things the way they are. But Faisel, I think we need to go back to 2003 and the passage of the Medicare Modernization Act, which I was also involved in this issue, where we first defined health savings accounts. Before that, we called them MSAs. Archer, named after Congressman Archer from Texas, Archer MSAs. And the idea was, well, we're gonna have a new model, and in this model, the individual is going to own the benefit. They're going to own the account. They're going to be able to keep the account. They're going to be able to roll it over. They're going to be able to use this money to save over the course of their lives if they're not using it on regular occurring medical expenses, to buy maybe a long-term care or whatever. And so there were the key problem candidly hasn't been that you can't take your money out of your HSA and spend it on the primary care doctor. The key problem has been that the way the law was written, the law said that an HSA has to be paired with a high deductible health plan. And the idea was the high deductible health plan is going to insure you and cover you for things, but it's going to have a higher deductible. So the consumer is going to have more skin in the game. They're going to think about the things they're going to do. They're going to become a better healthcare consumer. And to empower that, we're going to give you this account. And out of this account, you're going to be able to save triple tax preferred dollars, which is there's no other part of the tax code that lets you save for things the way an HSA does. It's one of the best tax vehicles we've ever created out there. But we're going to limit that spending to qualified medical expenses. And while out-of-pocket costs in a fee-for-service primary care practice could potentially be considered qualified medical expenses, the IRS said, well, sometimes they are and sometimes they aren't. And there's all of these definitions that go into 213D of the Internal Revenue Code. There's a list of things that are qualified medical expenses. And a monthly payment to a doctor for primary care is not one of those things. So first we did, and we went through years of a regulatory battle with the IRS. And in the last Trump administration in 2020, we codified essentially what we already knew, which was that the services provided for by direct primary care were in fact primary care services. They weren't other things, right? They were primary care services. So they were qualified as qualified medical expenses under 213D of the Internal Revenue Code. And so for the purposes of your FSA, your flexible spending account, or your health reimbursement arrangement, no, you could pay for DPC all day long, no problem. The rules around HSAs, though, because they are individual accounts, remember in an FSA or an HRA, that some money in the FSA can roll over, but most of it goes away. And then in the HRA, all of the money goes back to the company at the end of the year. Because the individual is keeping the account, the HSA has much tighter eligibility requirements. So in those eligibility requirements, in other words, who is eligible to fund an HSA? They say if you have a high deductible health plan, you have an HSA, it has to be paired with a high deductible health plan. You can have no other health plan or no other set of services that covers things, e.g. primary care, that are already covered in the high deductible health plan. Now, no matter how de minimis the coverage of primary care is in a high deductible health plan, we know that they at least have to cover, AB-rated preventive services or whatever. So IRS looks at that and says, we've got this thing over here, high deductible health plan, covers primary care. We got this thing over here, direct primary care, also covers primary care, double coverage. So if you do that, if you have this contract with a DPC doctor, you are now ineligible to fund your HSA. We didn't really know about this until about 2010 when I remember when Q Alliance, which was Dr. Garrison Bliss's practice, one of the patients, I believe, sent a letter to the state saying, hey, can I use my HSA for this? And the state of Washington contacted the IRS and said, hey, is this okay? And the IRS immediately came back and said, yeah, it's fine. And then they sent a long letter about a week later saying, well, no, it's not actually fine. This thing is considered a health plan that would make an individual ineligible to fund their HSA. So this person would not only have to not pay the primary care doctor out of the HSA, they'd have to refund all of the money in the HSA and pay tax on it. So that's, to my knowledge, the only, and it wasn't really an enforcement action, but it's the only time the IRS ever spoke. Then years later, we went back and asked, I think in maybe 2012 or 14, we asked the IRS, Senator Patty Murray from Washington asked the IRS, is this your interpretation? Because we've interpreted direct primary care to be not insurance, and we have now 33 states that have passed legislation, including the state of Washington, to say direct primary care agreements are for medical expenses, not for insurance. And the IRS came back and said, no, the way we interpret this, under the very narrow rules that govern HSA eligibility, that you are other coverage or a health plan, whether you're insurance or not, that provides services that are already provided for in the high deductible health plan. And so just unraveling that tangled web of how the law was written in 2003 took a number of years and a number of sit downs with the IRS. We always thought they had the power to fix this administratively, but didn't, couldn't, wouldn't for lots of reasons. I think the people in the health tax division at IRS don't like HSAs. They don't believe that they are the right thing to do. They don't like that you're, taking money out of their treasury to pay for things like primary care. And again, they're getting this special triple tax preferred status that no other account vehicle, no other, tax benefit really has. And so it was a hard fight. I actually recently had somebody come to me and talk to me about another potential tax issue. And I took a hard pass on it saying, that one would probably outlive me. So, I'll walk on to the next thing. But it probably start to finish was about 15 years to get this thing done.
Well, and we had Asaf Baton on recently, and he was talking about something that he had heard from Bill Gates, that we often overestimate the amount of change that can occur in 2 years and underestimate the amount of change that can occur in 10 years. And so with this being 16 years, but I would go back and say it was a stroke of genius for you to be able to get that definition in the ACA to begin with, don't you think? That gave you the toehold that you needed to make these other changes, even though it was small enough, maybe you got past the resistance that you would have gotten if you'd tried to take a full, get DPC completely in the health system right then at that time. Does that make sense? What would be your advice to people looking to make changes? How do you do that? How do you walk that line in between and get the changes that you can today and then live to fight another day?
Oh, Dan, you hit the nail on the head. I mean, I didn't play a lot of baseball when I was young, but my early Little League coach taught me base hits. Let's get on base. In 2009, 2010, we got on base. You're absolutely right. We actually leveraged the law in Washington State, which was called the Direct Practice Act, which predated the provision in the Affordable Care Act, was really the first law. And candidly, it was Garrison Bliss and the CEO of Q Lines, Norm Wu, and I were saying, well, people are starting to call this direct primary care. And I said, yeah, that sounds like a good idea. Well, we'll call it direct primary care. And I said, there's this other thing over here that's really popular. They call it a medical home. And, sort of like it's patient-centered medical homes, it's ACOs, it's like where you go to get all your care. And Garrison said, well, that's us. And I said, well, what if we called it a direct primary care medical home? Because a direct primary care might sound a little like concierge, and the Democrats aren't going to like that because they don't like concierge and they don't like things that are for rich people. A medical home is supposed to give everybody, no matter what their age or income is, a medical home, a doctor that they can call their own, a place that they can go to get their care. And if we call it a direct primary care medical home, we could probably walk across the aisle, and we have. I mean, I would probably guess we are the only reform in HR 1 that is in both the Affordable Care Act and in HR 1. So, we appealed greatly to the people in the Obama administration who wanted to expand health care to everyone, but they knew what they were really doing was giving everyone health insurance. So let's put a few things in here that are going to be seeds that'll grow, that are actually going to get people better care. We were also very involved in the creation of the CMS Center for Innovation. I had worked with the Vermont Blueprint for Health on some of the very early advanced primary care demonstrations. We were actually, the Vermont Healthcare Reform Commission was a client of ours. And what we did is we brought Medicare and Medicaid to the table when Vermont wanted to do the Vermont Blueprint, which was, we're going to make every hospital service territory in the state available to every primary care doctor. We're going to put a care team in place where they'll have access to a health coach, dietitians, the things that little country doctors in Vermont aren't going to be able to do for their patients, behavioral health and those sort of things, and make sure that every primary care doctor in Vermont becomes a medical home. That was the idea. So if you give, 5 full-time employees that are spread among 100 doctors in a hospital service territory, they can do some of those things that the primary care doc doesn't have time to do. And then I always looked at DPC as sort of the natural payment model extension that allowed the physician to begin to grow into a practice where the practice was compact enough and they were able to spend enough time with a patient to do those sorts of things, or to find the community resources and the resources outside of the practice that were going to be able to make that practice a true medical home. So in that environment, the small doc, again, given enough time, a well-trained family physician or internist, will have the time to find the resources for the patient to figure out, well, how am I going to pay for this med, or how am I going to make this work with my insurance, or where's the best place to go for podiatric care because I got feet aches, So I think it's a really good model to grow from, because the physician becomes not just your doctor, but again, the sort of spirit guide through the rest of this healthcare system, which is what you are all trained to do, right?
Absolutely. Absolutely. And I mean, it makes a huge difference. I mean, Faisel has all sorts of stories about the impact it's making in these needy patients.
Yeah. I mean, so many people they're just desperate to have that relationship. You've got You've got in the underserved populations, if you're looking at the 30 to 60 million Americans who are really struggling hard with their day-to-day lives. And then on top of all of that, because of the lack of access to like basic social things, we're seeing that manifests itself with unnecessary emergency room visits, right? If we would have just addressed the social issues from the beginning. And so with the value-based care movement, a lot of that work being done in these underserved neighborhoods because of the way everything was all set up, like it was created as an incentive to go into these underserved neighborhoods. We were able to see a lot of relationships, beautiful doctor-patient relationships, health system patient relationships to people who just didn't have that access before. And then at the same time, you have the rise of the direct primary care movement for most of anyone else. And now it's all been cleared up. And now starting in January, anyone with a health savings account can use that money for direct primary care. So, I think we're still a very young population of people. Like the average Japanese person's age is almost 50. In America, we're still very, very young. Our average American is like in the mid to late 30s, pretty healthy, when you think about it that way. But my goodness, for the everyday person who just wants to have easy, affordable access to their doctor, what does this mean starting January for that person?
It means a lot of things. And there's really, I would say, three major things that this bill does. The first being, obviously, again, direct primary care has been definitively in now, again, 34 states around the country within the Department of Health and Human Services for the purposes of the Affordable Care Act, and now in the tax code. Maybe the most meaningful thing for me as a policy person is that every nook and cranny of the state and federal government now realizes, direct primary care is not a health plan. It is medical services. So that's really good. The second piece you mentioned is that, you can now take money out of your HSA and spend it on your monthly fees or whatever, periodic fees for direct primary care. And those are important. But I think the real power in this comes from the partnership that we have had with employers, large and small, over the years, who have been clamoring to offer direct primary care as a part of their health benefits, but have found, because most of these employers now offer, and some of them only offer, high deductible health plans that are HSA compatible. So I think the two most important things that this bill does is, number one, it says if your employer are offering a high deductible health plan with an HSA as a part of your health benefit for your employer, the employer can now pay for a direct primary care benefit that'll work with that plan, and the two can work together. So we worked really closely with Boeing that can only do this for their employees that don't have HSA high deductible plans. So if you have the PPO or the HMO, you can get direct primary care. But if you have the HSA high deductible plan, you can't. So that's off the books now. But there's one more piece of this because of where this was written in 221C of the Internal Revenue Code. The payment to the direct primary care medical home now comes before the deductible. So imagine a world in which you have a $6,000 deductible health plan and you're paying $150 a month, or let's because I'm not a math guy, let's call it $1,000 a year towards your direct primary care. At the end of the year, that $1,000 is in front of the deductible. So you now have a $5,000 deductible instead of a $6,000 deductible. So you're making it easier for the patient to afford services in the high deductible health plan. You're essentially making the high deductible health plan much better. So think about a world in which your health plan was for 90% of the care you're ever going to need in your life from your family doctor or your primary care physician. You're going to be able to pay $60 a month, and you're going to be able to pay it out of a tax paid account, or your employer is going to, pay for that for you, and it's going to be free. So essentially, you're going to have first dollar coverage for 90% of the care you'll ever need in your life. And then when you need it, you've got this high deductible health plan. It's essentially catastrophic coverage that wraps around that plan. And Faisel, I think the next mission is, we need to do this in Medicaid and in Medicare. We have a bill that is a bipartisan bill sponsored by Representatives Dan Crenshaw And Dr. Kim Schreier from Washington State, it's HR 1162, the Medicaid Primary Care Improvement Act, that would require CMS, number one, to, if a state comes to them and says, hey, we want to figure out a way to do direct primary care in Medicaid, they would have to do that. And there have been several states that have asked CMS to do that. And it would also require CMS to get together with the state Medicaid agencies, the physicians who are interested in practicing in this model, the direct primary care physicians, so the Medicaid managed care companies, put everybody in a room and figure out how it works in each state. Because we're never going to be able to write a federal law in Medicaid that would work right in every state. It's a state federal program. So it really sets the table, this bill, for people to figure out a way to do that in each state. And obviously, Massachusetts would probably do things differently than Texas would. But I will tell you, there are officials in both of those states that are interested in figuring out a way to get, like employers get, the state Medicaid agency to save 20% of the total cost of care by bringing better primary care to a Medicaid beneficiary. Likewise in Medicare, I mean, the principal problem in Medicare is if you're in DPC, you have to opt out of being a Medicare participating provider to do DPC if you ever want to see anyone who's over 65 and is in Medicare, because if you're in Medicare and you're a participating provider, the only money you can take for primary care services for that individual is the Medicare physician fee schedule. And if you said, no, I want $100 a month instead of taking care of my patient for, 92124, then you would be violating federal law, because that's not a part of the fee schedule. So we're working really closely with the Senate Finance Committee, with CMS and others, to get to a way where perhaps the primary care, services that are now full of those E&M codes that are in there would be offered in a monthly global fee payment to a physician who would say, okay, for these services, I'm not going to take fee schedule, but I will take a set monthly fee. I will say that rubs our members the wrong way in a lot of cases, because they don't ever want to take money from Medicare, and we're thinking about some workarounds for that. But for those who would take $100 a month to see a Medicaid patients, you would say, okay, I've agreed I'm not going to take any of the CCM codes. I'm not going to take fee-for-service codes. I'm not going to do any fee-for-service billing in there. I will take $100 a month, or whatever the number is. This is theoretical, to see X number of Medicare patients. And both Democrats and Republicans on the Senate Finance Committee and people within CMS in the last administration and in this administration think that's a way forward. And I think that'll be something we're looking at working at really closely. We would like to figure out a way for that patient to be able to pay the primary care doctor directly, which is the model the way it works now. We might be a couple of steps away from that in Medicare, but we think we could probably do it in Medicaid pretty well.
I mean, I was just looking at some statistics I've seen recently. So from changes in, just because of rising healthcare costs, personal health insurance is going to go up by double digits next year. Pharmacy cost, I heard earlier today, is now 8% of the healthcare spend in the U.S. and rising at 11% per year. Emergency room visits emergency room care is like 6% of healthcare spend. And at least in Virginia, primary care spend is only 2.5%, except primary care is the only specialty proven to improve outcomes and reduce costs overall. So putting copays in front between the primary care doctor and the patient is like putting a coin slot on the dashboard and asking patients to drop a quarter in before you put your seatbelt on, right? I mean, from a societal standpoint, it makes no sense. So I think this is just genius what you're coming up with here.
Well, thank you. I mean, again, I was certainly one of the original authors of the bill, but it was not far from all me. This was a long effort that stretched over a lot of people, and the employers fought really, really hard for this. They see this as a way forward, and it really does go back to that provision in the ACA, because what we did for them, they said, oh, well, if we offer this direct primary care along with a really skinny health plan, we can make the skinny health plan count towards the essential health benefit and, reduce our downstream expenses, because we've shown, the Milliman study you're probably aware of shows that employers have reduced their cost of care by up to 20% on an adjusted basis if they put DPC in front of the PPO. So employers have embraced it because they love it. And to your point, again, it's a double, triple benefit. They get happier employees that show up to work more often. They're getting a health benefit that they love because they're getting Dr. Dan instead of Aetna or Cigna or nameless bureaucrat on the end of the phone who's prior authing your CT scan that your doctor said you need out of existence, So it's a big change in the way we would deliver healthcare. Again, if you imagine you could carve out 90% of what we ever do in healthcare, I always liken this to, auto insurance, right? We don't insure tires and windshield wipers, blades, and oil changes. We pay for those up front. You don't go to, Target and buy a can of oil for your car and say, well, here, I'll reimburse you on the fee schedule for your oil. You go and you buy it and you put it in your car and you're buying oil changes and windshield wiper blades and tires, in primary care. That's what keeps your car running. So we're going to keep all the people running by all this stuff and it's cheap. So why don't we pay for it up front? And why don't we get healthier people? And then, we did some back of the envelope numbers with some of these more forward thinking insurance companies. And I think you could probably today, if you divided the pie of an advanced private insurance health benefit where you're going to spend $100 a month on primary care, $100 a month on other stuff like ancillary stuff like labs and x-rays and, crutches and DME and whatever. And then you're going to spend $400 a month on catastrophic healthcare plan. You could get first dollar coverage for every man, woman, and child in America for $600 a month. Now, I don't know about you. I pay about $2,000 a month for a $7,000 deductible healthcare plan for me and my wife as we approach Medicare age. Yay. And are able to get rid of that. But you could start talking about universal care in this country at $600 a month. You can't at $2,000 a month. But what we've got to do is we got to cut out a lot of middlemen. You mentioned pharmaceuticals. As you're probably aware, most DPC docs in states where they're allowed, Texas and Massachusetts, I think are the only ones you can't do this. They dispense, 50 or 60 different generic medications in their offices for $3 to $10 for a monthly fill. And the other part of pharmacy that's changed is there's about a 60% fill rate for the prescriptions you all write because people either can't afford their prescription or they don't feel like going to the pharmacy to fill it. So, what if you hand the Lipitor to the patient on the way out of the office and say, hey, that'll be $3, which is $7 less than your $10 copay if you use your PBM. So if we get the PBMs out of the way and we get the insurers out of the way for all primary care, okay, now we're going to pay for meds by upfront, like we pay for oil at your Costco or your Walmart. We're going to pay for primary care up front. And so we're going to have a well-running machine that now only needs a catastrophic healthcare plan. And that's my vision for the way this fits. We could really change the way overall care is delivered. And you want to talk about value-based care? That's the highest value care you could possibly get for anybody. And we are engaged with CMS about making this work in some meaningful way using the CMS Center for Innovation. And we in 2018, we went down the road of doing this. We flew around the country with CMS doing focus groups with DPC docs to try to tell them what would be a really good way to do this in Medicare. And they came up with the ACO REACH program, which wasn't exactly direct primary care, but it had its inklings, and there was a kernel of it there, and certainly moving to a monthly fee is part of that, but that's not all of it. All right? But I think in this law, there's the leverage, the policy lever we need to get to the vision that I was speaking about. We do a lot of work with the Health Rosetta brokers. They're all very attuned to this idea. Brokers are hungry to sell policies like this that bring high value to their employer customers or their health plan customers. You mentioned health plans. We worked with the CHI in Nebraska, and they do direct primary care for their employees in the hospital system because they see the value of it, right? And lots and lots of strange bedfellows here. And I must say that, AHIP, the insurance lobby, didn't oppose this bill. The American Hospital Association and the Federation didn't oppose this bill. Nobody opposed this bill. Well, there were a few a few DPC doctors that didn't want to be told how much they can charge in an HSA arrangement. They didn't like it. But, outside of that, nobody opposed this bill because everybody in the healthcare ecosystem thinks this is a good idea. High value care for low dollar.
Yeah. So just one point of clarification here. So the bill doesn't tell the DPC docs what they can charge. It just tells how much you can spend out of your HSA account. So
it's slightly different. It's very nuanced. So to qualify for this exception to the tax code, which defines a direct primary care agreement as not a health plan, that plan must be a plan that is less than $150 a month. So what it is doing is it is defining the universe of how much triple tax preferred dollars can actually be put into this service. Because if you let it be, if you let the n equals infinity of what you could charge in this, the Joint Committee on Tax, it made their head explode. They said, well, Kaiser could do this and offer every service under the sun and just call it direct primary care, and then there would be no money left in the Treasury. The way it is, the Joint Committee on Tax assumed that there would be a $2.81 billion hit on tax revenue that would be collected, that would be saved by individuals, put into their health savings account to spend on direct primary care agreements, because they realize, they assume that this is such a great thing that everyone is going to want to do it. So, and I think they're right. Who am I to say they aren't right? So imagine if it were $1,000 a month that they could put in. You're growing that number of assumed revenue to be very, very, very high. So it really is. It was a feature of keeping the score and the impact on the potential revenue to the tax code down. But by our measure, what if you made the employee workforce 20% healthier by doing this? What would happen? People would be at their jobs more often. They'd get promoted faster. They'd get raises. They'd pay more taxes. And we think that all of the productivity gains that would be associated with better primary care would far outweigh the amount of money that's going to come out of the Treasury and to be put into a direct primary care agreement from your HSA. Although I will say that the CBO and the Joint Committee on Tax didn't buy that argument. I think legislators understood that this wasn't spending. This wasn't a costly bill, even though it scored high. It was a bill that saved the American taxpayers $2.8 billion. So, that was another hurdle we had to fight. We had this bill in the House version, and then the Senate came over and said, we're not going to put any of this stuff that spends federal dollars in our version of H.R. 1. So the first thing that we went to the sponsor of the bill, Dr. Bill Cassidy, who is the chairman of the Senate Health Committee, one of the four negotiators on the bill. And we said, hey, Dr. Cassidy, we said the same thing to Senator Mike Crapo, who's been a longtime supporter of this bill. We said, hey, this isn't spending. This is a tax cut to the American people to the tune of $2.8 billion that's going to let these people save money into an HSA and spend it on better primary care so Medicare and Medicaid don't have to do that. So don't you think that in a world in which you're going to take all of these people in the expansion population and tell them to go get, a job because you have work requirements and their employer is going to now cover you with your health benefits, why don't you let that employer give them a health benefit that means something to them? And so, they bought that argument and put us back into the bill after they stripped us out. And I have to say, Senator Mike Crapo, the chairman of the Senate Finance Committee, who I've known personally since before he was in Congress, is like that idea went off like a light bulb in his head. He said, yeah, you're right. This isn't spending, it's a tax cut. So we found our way into the largest tax cut in American history as a tax cut that'll allow people to save for better primary care.
Wow. Jay, I got to thank you. Thank you so much. I mean, this conversation has been such a gift. I mean, this bill is such a gift for everyone, not just for the DPC world, but really anyone who's felt like their health has been managed by numbers and codes and authorizations as a struggle between the doctor and the insurance company and this is just a great, great moment showing that policy can actually catch up to the practice. And, most of our listeners, they're medical students, primary care residents, people who are geeky about high quality primary care. I mean, this is proof the system can change, and direct primary care just got a major boost.
Well, I thank you for having me on. And I would say to any of those medical students or primary care doctors to go to dpcare.org. Join us. We'd love to have you as our members as we continue this fight into Medicare and Medicaid and other issues that we're going to have to do with implementing this law. I mean, it's time to execute, folks. You've got to now present America with a health benefit that they're going to want to love and pay for. And so I'm thrilled to be on with you guys today. Thanks for doing what you're doing on the podcast. It's great.
What are your thoughts on Beyond the Copay, DPC, HSAs, and the politics of change? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.